Welcome to the Inside Infrastructure Podcast, a podcast that explores the ins and outs of infrastructure policy and the people behind it. I'm your host, Janice Lee. I'm a partner in PwC Australia's Integrated Infrastructure team. Alongside my co-host, Adrian Dwyer, CEO of Infrastructure Partnerships Australia, we're so excited to be bringing you the stories of prominent leaders that are shaping the future of Australian infrastructure, from CEOs of top ASX-listed companies to Australia's top brass. Today, we speak with Rebecca Wark, the Chief Executive of Health Infrastructure. Previously Executive Director of Rural and Regional Projects, in this episode she delves into her many years working in country areas to deliver critical health infrastructure, overseeing New South Wales Government's record investment in regional health. Rebecca speaks about the importance of culture in project delivery, the history of health infrastructure, her journey through the public sector, and so much more. We know you'll enjoy this one.
So Rebecca Wark, welcome to Inside Infrastructure. Maybe you could tell us a little bit about who you are and what you do.
Thanks, and really pleasure to be here. Thanks to you, Adrian and Janice. I'm the Chief Executive of Health Infrastructure and really proud to lead the second largest infrastructure portfolio in the state, behind transport, and the largest health portfolio in the country. My role is really a leadership role to engender fantastic culture in our space so that we deliver great projects with high engagement and future-focused health outcomes for the people of New South Wales.
So could you tell us what health infrastructure does? What's it responsible for?
So we're a part of New South Wales Health, and we're responsible formally for any project which is over $10 million. But that may be a program of works of much smaller projects. So, for instance, it could be the Rural Ambulance Infrastructure Reconfiguration Program, which is a whole raft of smaller projects, and we've just had announced the second stage of that, so another $100 million program of ambulance stations in the bush, regional and rural areas.
So you're responsible for the building and then the maintenance of the estate, is that right?
So originally, and I think our reputation has been around being builders, the deliverers of infrastructure. We're now much more than that. We've now been tasked with a piece of work on asset, looking at the entire life cycle of assets. So working with local health districts to look at their, the whole of life of assets, and so we have a role in that to comply with the new Treasury policy around asset management procedures, and we also now have a much stronger role in the precinct space. So we're not just builders anymore.
So you said earlier the largest infrastructure deliverer behind transport. Could you just give us what is the scale? How many hospitals are we talking about? How many people in beds? What's the...
So we have about 100 current projects at the moment.
So that's things with people building them now? Or?
They're not all in construction. Right. So we go from pre-planning and planning all the way through delivery, commissioning, and then into operations. So I think we have 40-odd projects in construction. Our pipeline is now almost $20 billion. This term of government, we are delivering $10.7 billion of works. So they're not all hospitals per se. Some of them are health ones, which are smaller community health type projects. Some of them are multi-purpose facilities in very small regional or remote communities where they might be a combination of some acute services, a couple of hospital beds and some aged care beds.
Health infrastructure is just known for being a very sophisticated delivery agency. How do you keep your head across that many types of projects? And how do you manage risk across them? Because from what I've seen, some of those hospital builds are the most complex projects around, just in terms of, stakeholders and expectations and the actual builds themselves.
I think the answer to all of that is through having a great team and promoting really a very strong culture. So my personal vision is around, if you have a great culture, you get good engagement. If you have good engagement, you'll have great outcomes. So that means working with your stakeholders, being respectful, a lot of consultation. We have the way our structure is set up, we have a number of regions. So we have effectively Sydney Western, Sydney Central and Northern, and then rural and regional. And each of my team that look after those spaces is now looking after a business which is, in its own right, bigger than health infrastructure was 5 years ago. And so each of those executive directors is looking after $6 or $7 billion worth of work.
And having that outlook then, is it about just the way you engage, or do you end up having to set up deliberative process? Like, does it slow down the planning process? What does that look like?
I think it's around having a series of processes which we follow fairly rigorously. It doesn't mean you do everything to the letter, and we make mistakes, and it's about, I think I'm strong on the 80%. You're better off doing something and fixing up some things along the way than getting everything right before you actually push the go button. We don't. It's not always perfect.
That's kind of hard in health, though, isn't it? Because that minimum viable product in health means that almost by definition you're taking on some risk that people are going to get less than optimal outcomes.
Well, I think there are some processes which you are absolutely diligent about. And an example of that would be the commissioning of medical gases in hospitals when you're finishing a hospital and handing it over, and there's very strict protocols around that which involve anaesthetists and a number of different parts of the system. But that might be different to the risk that you analyse around what the design layout for the best sustainability option might be. I guess there are varying degrees of acceptable risk in that space.
We delved into some details, but we should probably take a step back. So you with health infrastructure about a year after it was first established, is that right?
So my first introduction with health infrastructure was in 2008 when we were about 10 people in Chatswood. And I think we had 4 or 5 projects. A couple of those were PPPs. Then after a couple of rounds of maternity leave, I came back in 2011 and have been with HI since then in various roles, from project director, director of planning, through executive director of rural and regional. I have an absolute passion for the bush and for trying to deliver improved health outcomes in that space. And today is National Sorry Day, and I think we're all reminded about our obligations of looking after Aboriginal people, and that's particularly the case in some of our remote areas, about ensuring we get some more equitable care in that space. But I think the more that we can do in regional and rural areas, the better our system will be. And that's not trying to build tertiary hospitals in a small country town. It's about building the right services and working with districts so that the most contemporary models of delivery of care are able to be provided.
We'll probably come to the contemporary models of care later, because it's something I know Janice and I are both interested in, what the future is in health. I just want to go back to a little bit of those early times. So you started as a project director, but our research says that you're not an engineer. What are you?
Is that a good or a bad thing?
I no value judgment. I know lots of very good engineers. I just landscape architecture. That's what
that's true. So I'm a landscape architect originally. I worked in infrastructure, in landscaping. Went outside on a job in let's not talk about how long ago, a long time ago, and didn't come back inside for many years. So I've spent a lot of time in construction. I've had roles in public and private sector, which I think gives me a good range of experience to run health infrastructure as an enterprise. This
is a naive question, I guess, but what is a landscape architect?
All of the external design that goes with architecture.
So it's not like the built form, it's how it fits into an environment.
Well, I did a major in urban planning and urban design in my landscape architecture, which I think is of benefit in this role when we're looking at how to fit a hospital into a precinct and what might be the complementary uses, and that you're looking at good, solid design principles, not just building a hospital as an island in a suburb or in a town.
There's a striking thing about you go to a newer hospital versus some of the legacy parts of the system is that they look less like hospitals.
And I think that's a really positive change in recent years. I mean, most people don't enjoy being patients in hospitals.
Because typically something bad's happened to you.
If you can make it a more pleasant place to be, I mean, the research shows that people get better faster. So it's about not having everything stark and white. We now have an Arts in Health program, which isn't just about putting paintings on the wall. It's about involving people in what those spaces are like in different programs. It can be music programs, it can be Indigenous engagement programs, quite a lot of mental health programs. So it's about making those spaces as good as they can be to make people feel better.
Does that change the function of a hospital? And it probably gets into where I was hoping to sort of ask next, which is, how are hospitals changing? What does the future hospital look like? And what is the constellation of additional services and functions that sit around it?
I think one of the things which we in life are becoming, as people, we want to be more involved in our care, whether it's designing your own gym program or what your own home looks like, or it's about people want to be involved in their care. They want to have a say in how the services are delivered to them. And that can be also, we need to harness a lot more digital innovation in that space. So the services that we can have around having an app that might tell you if you've had a break from your son at soccer, when should you turn up in the fracture clinic so that you're not sitting there on Monday in fracture clinic for 7 hours. You could say, okay, we know we're 7th in the queue and that they'll text me half an hour before. So I think it's really simple things like that can make everyone's life or make their healthcare experience a better experience. And so there's some of the innovations that we need to harvest.
Does that mean that health is working with a much wider group of businesses? Like, does it change the way health and health infrastructure engage the private sector and the not-for-profit sector and the technology sector?
We're certainly finding there's a lot more opportunity there to collaborate with both industry partners, research and education partners around how those services are delivered. One of the challenges that we have is there's a huge capital investment now in hospitals and in healthcare, and we need to be able to maximise the efficiency of that as to how hospitals can afford to be run, the recurrent costing. And if we can collaborate with industry partners around that, then I think there's a lot of opportunity to how to do that more efficiently.
Can I ask about COVID-19, the pandemic, to what extent that's accelerated that pathway?
It certainly has accelerated things like telehealth, where a number of clinicians were previously less inclined to move forward in that space of telehealth. And now we all know that Zoom is just a way of life for many of us. So it's accelerated that through necessity. But and it's also about virtual care in many instances, which is one of the pillars of the 20-year health infrastructure strategy that New South Wales Health has, is around how do you provide those services differently, and that virtual care where you might be in hospital as a patient for your surgery, but then your follow-up treatments may be able to be done more locally, and some of those may be able to be done in your home through virtual connection with your clinician.
Is it an acceleration of a trend you knew was happening, or is there a diversion from where you thought the infrastructure need would be?
I'd say it's probably more the former. It's an acceleration of that, and it's also a general acceptance of we have to change the way we do things.
Has it changed though? I just remember telehealth always being talked about as a remote service option, and I think what's interesting about COVID was that people in the inner cities were using them, and it was based upon what the health need was, or the age profile. Like, do you feel that it might have changed the ways in which we would use telehealth, and would that likely stick beyond the pandemic?
I think it will stick beyond the pandemic. We're finding that now. There are many, if you look at an appointment with your GP, for many now you don't have to go and sit in the waiting room and see your GP face-to-face. You can elect to have a telehealth appointment. In the COVID space, Many of the admitted COVID patients, unless you're seriously unwell, are monitored in their own homes through the virtual hospital. Mm. So they might have monitoring in their home.
Oh, I didn't realise that. So that like there's equipment delivered to their home that they're hooked up to.
Yeah.
Yeah, and that's all just through your Wi-Fi.
Yes, and you are still deemed to be a patient of a particular hospital, but you are able to do that in your own home. And it's a far more efficient way of treating people, and it puts them in a much more comfortable space.
So you're going to have to map out for me here. So you deliver and look after a substantial estate of infrastructure in health, and yet a lot of what we're talking about is a low infrastructure intervention. Like it's not necessarily people in a hospital for an extended period of time. You spoke about an app that tells you to come to the hospital half an hour before your appointment, which reduces the size of the need for the waiting room and all these other things. So we've built this huge 30, 50-year infrastructure for a potential future that has much lower demand for infrastructure. Is that right? Or?
So the challenge for us then is not just building bigger hospitals, but building smarter hospitals. So the investment of the infrastructure may still be the same. And look, there are different design developments around what is the best design of an inpatient unit, for instance. Should the beds be side by side or should they be toe to toe? What does that mean a nurse's station might look like? So when we look at sustainability, it's not just around environmental sustainability. It could be around workforce sustainability where, if you design something in a particular way, does that mean you need more nurses or fewer nurses? Does it mean you need more cleaners, or can you do things in a smarter way so that you need fewer actual people to do things? It's not about costing jobs, but it's about, is there a better way to do things so you're maximising the efficiency and the services which you're providing?
So how much of when you build a hospital is it just a flexible space that will be used for different things over time versus that more specifically designed for a purpose?
There are a set of guidelines called the Australasian Health Facility Guidelines, which give us, for instance, what a standard operating theatre might look like, or what an inpatient unit might look like, or what a dirty utility room might look like. But we are testing the boundaries a lot more on those about saying, what does contemporary care look like? If you take, an increase in ambulatory services, so where people go to outpatient clinics for things, do you need, is there a maximising of shared spaces? How big do your waiting rooms need to be? So there are some developments in that space consistently around improving that, which really depend on how the model of care is going to be delivered.
Okay. I would love to start talking about your journey to chief executive. So you mentioned that you'd been the executive director on the regional hospitals side of HI. How does that prior experience inform your approach to being the chief executive of health and infrastructure? It's somewhat of an unusual trajectory, going from a regional kind of arm of the organisation into the leadership role. So does it give you a different perspective about leadership there?
I think for me the most important thing about leadership is the people. And that doesn't make any difference about whether it's a rural or regional portfolio or a metro portfolio. It's about looking after people's well-being. It's about focusing on how we provide the best workplace to enable the strongest results from people. I think to go to Adrian's earlier point around how has COVID changed what we do, immediately before COVID, we adopted an agile workplace policy. And I'm really proud that we did that because it actually put us in a good position during COVID. We were agile, everyone worked from home, as did everyone across the world, I think. But it's really allowed us to normalise a different working space. We promote people whether you'll often find me in the car if you ring and people say, is it okay to talk? And I say, yeah, sure, I'm just on the school run, but chat away, my kids are used to it. Or I might say, can I ring you back in 15 minutes? And I think that is now, and at HI, that's the culture we promote. It's a lot about family first, whether it's around a close friend, young kids, or aged parents. It's about what are your needs and how can we best accommodate that in the workplace.
I'm just hoping it's the death of the suit. Like once you've gone through a process of sort of seeing everybody in their own living rooms in a T-shirt and shorts, can we get rid of ties? Can we agree?
It's a long time since I've worn a tie, Adrian.
yeah. It's a long time since I've worn one as well. But I've decided, coming back from a pandemic, there's no way I'm wearing ties anymore except for meetings with ministers and possibly visits to Parliament more generally. But other than that, ties are out.
It was a strange year last year, sort of suddenly being in everybody's living rooms, sometimes in their bedrooms, you know, just seeing so much context for them. I just found that the most extraordinary way of working.
I maybe think it brought us closer to people that you were...
Provided you had established relationships, yes. I think for some people, like I just found with new people coming in, like graduates, it was really disorienting for them to not ever have face-to-face meetings. But I think if it's people you've met professionally and suddenly you're seeing their study and you're seeing their kids run in, it did create an intimacy.
How did you deal with that with sort of graduates? And you would have stood up a bunch of projects during...
We had our biggest year ever last year during COVID. This year will be bigger, but we really emphasised how we kept our project offices running, which was a challenge because, you know, the Premier was very clear. We didn't, from an economic perspective, we couldn't slow construction down. So we had to keep our sites running. It was about making sure that we were keeping people safe. It was about being respectful about what they needed in that. So it was things like more lunchroom facilities, additional vertical lifts for construction workers. And it was, we had a very big year last year. And, you know, I think it normalised that balance between discipline and agility and flexibility. So we encouraged people to work from home where they could. We closed our, our main office, but we still had to keep our project offices running. And you can't expect construction workers and project managers to be on site if your own people aren't on site as well. So it was quite a tricky balance for some time.
And did you have any of the kind of COVID surge facility stuff that you had to stand up?
We stood up a project management office overnight in March of last year. What was really pleasing for me as chief executive was we set up that project management office to help the entire state response, but it didn't affect our business as usual. So we did a seamless backfilling because everyone just got in and got involved about what had to be done. But yeah, we had a role, we had 4 or 5 legs to that role, so we accelerated a number of projects. So we accelerated the completion of the new acute services building at Westmead and a couple of regional hospitals at Maxville and in Mudgee, because at that stage, you know, Italy was an absolute disaster. The UK was very bad, and we didn't know what was going to be coming and facing Australia. So we accelerated projects. We looked at projects that we could retrofit in different spaces. So, for instance, there was a building at Royal North Shore Hospital, which was a previous clinical building that had been converted to administration. We converted it back so that it could be used for COVID surge. Thankfully, none of that was ever required. We were involved in the negotiations with the private hospitals around commercial agreements for surge capacity as it was required and bed space. We're involved in those early days with setting up hotel accommodation to be used potentially as less acute hospital spaces. And we also designed a number of different temporary hospitals. So we designed a major temporary hospital to put into Sydney Showgrounds at Olympic Park. And we based that on the Nightingale Hospital in the UK, which we consulted, spent a few Sunday evenings, I think, talking with colleagues in the UK about lessons learned, what works, what doesn't work. And thankfully, we've not needed any of that, but that's part of pandemic planning. You hope you're never going to need it. And we designed a similar sort of facility in a regional area and then a number of bolt-on additional facilities for hospitals, an extra 20-bed type facility. And again, thankfully, we haven't needed them. But there are some ongoing design changes which we've made around air conditioning and different design of spaces so that should you need to have a particular COVID pod in a hospital, you can have that without isolating then the whole of your intensive care unit.
So there are, even though we didn't need those facilities, thankfully, in the end, there are things where we're building a more pandemic resilient health system.
Absolutely.
Now.
Yep.
Are they big things, or are they optimizations on the edges? What did you learn from it that you didn't expect, I guess, is my question.
I think it's around segregation of spaces.
Right.
So that you can continue to operate a business as usual hospital, but still have COVID patients in those spaces. And there are, in mechanical ventilation, and we've been working with the teams around hotel quarantine. So we are advisors in that space around how what separation of air should there be. And so I think we've got a role. We've had a fairly broad role in a number of different spaces during COVID, and I think it's really helped us in a response, and I think our agility in that space has helped.
Now, the next question I'm going to ask might go to Janice as well, because I know she was involved with the 20-year health strategy that you played a big part in, that was released 6 or so months ago. One of the other inputs into the future of healthcare is an ageing population with more chronic illnesses and alike. How does that sort of changing demographic change and I guess just general population growth? How does that change the way you think about the future of health?
So our corporate strategy for health infrastructure was released a few months ago. That's underpinned by the 20-year strategy, which you're referring to. And it's, that's follows some key trends. It requires new ways of thinking and planning, the delivery of health services and facilities, and that the number of pillars that we have in our corporate strategy is around services, efficient delivery of those services, who we partner with, what our people and culture are around. And then in each of those we have priorities around how we maximise the best efficiencies in that space.
And your answer, Janice?
More questions, really.
Oh, go on, then.
I think it's really interesting, and we're living through such a period of innovation in health, and that strategy was a first insight into where New South Wales Health would take this. And I'm keen to hear your thoughts about, how does digital health and all of the sort of telehealth models and the different service models we've talked about, what does that mean for the hospital itself? What does the hospital look like 20 years from now? Is it much the same as it is today, or is it, doing more, doing less than it is today?
I think for us, the challenge, and I think we touched on it a bit earlier, is there's so much capital investment now, and the pace with which we're running at means there isn't a lot of time to stop and breathe and think about that innovation. So it's how do we best collaborate with our partners to harness that now, so that digital innovation, for instance, it might be a statewide service or it might be something which we just run in one facility. What does that look like, and how can we future-proof so that, in 5 years when the next technology is around? I remember when my sister was in hospital probably 12 years ago, I was using a BlackBerry. Now, my kids wouldn't even know what a BlackBerry is. But, an iPhone wasn't around then, and you think of the changes in that decade.
Totally.
We can't imagine what the changes in the next decade's going to be, but it's around trying to get, the maximised flexibility so that we can come back and retrofit later.
In the planning of that, do you have these difficult conversations where you're thinking, right, this whole area of medicine, which is currently a ward over here, might not even be needed in a hospital in the future? It will just be an injectable medicine, or, how do you plan for that level of disruption?
It's around, again, flexibility and agility, I think. So, there are advances in medical research. It's around people wanting personalised care. It's about social shifts and different demographics in different areas, and that technical and digital innovation. You can only plan for it by providing, in the built form, flexibility of spaces. So, you might have, we have standard floor-to-ceiling heights, which gives you a certain amount of space in your ceiling space to come back and do other services later. We have, might seem a minor example, but we design hospital car parks on a certain grid pattern with a certain slab-to-slab level so that later, should it be required, they can be retrofitted into hospital spaces. Mm-hmm. So it's providing that sort of agility and flexibility. It's also looking at, in a campus and a precinct, what other things could go into those spaces that over time, are different to being a hospital per se, but provide a different service model within a precinct for all of the people in the communities that use those precincts.
So I wanted to talk about that change in framing of a hospital towards kind of health precincts that's happened over the last few years, few in New South Wales, and I'm sure there's others around the country and around the world as well. But could you maybe tell us about that idea of going it from being a hospital to more of a campus type approach?
Well, the Premier has a very big focus at the moment on the Westmead, well, a couple of precincts, but Westmead is one that we are very involved in. And that's around, at Westmead there's an adult hospital, there's kids hospital, there are a number of medical research institutes, there's some space at Cumberland now which has an innovation hub around that for startup businesses. There's an innovation centre in collaboration with Sydney University, and we're looking at what are the other partners that could be involved in that space, and that's working with people like Amy Brown at Investment New South Wales. Who should we be attracting in the market globally? How do we best market New South Wales for economic uplift? And what does that look like in that space? And I think it's about large and small. It's about different uses of spaces. It's around collaboration in a number of different areas to actually harness that innovative thinking.
So how do you change the culture of, say, your organisation to go from thinking about building a widget to thinking about a space where other people build some widgets?
It's about the people that you have involved. So it's about having the right subject matter experts injected at the right time. So we now have different commercial expertise to look at investment attraction. We have different precinct-type designers that are, more experienced in
Any
that
landscape
space.
architects?
Only one that I know of.
Okay.
Is that approach working? So are you seeing different types of businesses or different types of talent coming to Australia as a result of that model?
Yes, we are, and I think it's fair to say that I'm not currently expert in that space because it's previously been run by others within health, but we have a much stronger role in that, and it's about sort of interweaving the infrastructure with the other opportunities in that space. And so by the Secretary, we've been asked to have a much stronger role in that commercial space. So we're bolstering the people. So to answer your question, Adrian, how do you do it? You do it by having the right people on your team. And you do it by collaborating with other people across government, in other agencies, to make sure that you are working together to get those best outcomes. And then you do it by collaborating with industry.
I was looking at health, and actually it is a bit of a standout because it has a lot of very senior women in the cluster. And it leads me to a twofold question, which is, are women doing well in health? And does that change the culture? Would be my first question. But the second question I wanted to ask was, I know that you've done quite a lot in the space of mentoring, and I'd love to hear some of your thoughts about how health is bringing up that next generation of women as well.
Well, there are, the facts speak for themselves. There are quite a lot of strong women within health, with people like the Secretary Elizabeth Coff, Dr. Kerry Chant, Susan Pearce, who's been very involved in the COVID response and the vaccination response. But in health infrastructure, we are really trying hard around diversity. That's not just around diversity of women, it's around diversity in age, in cultural backgrounds. But I think it is important to know, yes, I'm a woman who's a chief executive. Every person that's appointed in our business needs to be appointed based on merit. They don't get a job because they're a woman. They get an opportunity. And if they are the best person for that job, then they will get the job. And I think for me, that's an equally as important message as saying we have a lot of women that work in our business. We have a lot of young people that work in our business. We've got a number of older people. We've got a number of people from different cultural backgrounds. We've got some people who are refugees. We've got Aboriginal people. It's about diversity and providing opportunity, providing a safe workplace which promotes well-being, which includes cultural well-being and diversity.
And what sort of advice do you give? So young people or people from minority backgrounds, people with different gender orientation, like what advice do you give them as they navigate their careers?
Be brave and bold. Have a go. Be ambitious. Being successful at anything involves hard work. And surround yourself with people whose advice you trust. And I think, with those sorts of things, you can really achieve a lot. And it's about treating people the right way as well. So it's a lot about respect, collaboration, openness, empowering people to get things done. And I think we talked about it a little bit earlier. You don't have to get everything right all the time. Have a go. And working with people, you've got your back. I will support anyone who makes a mistake if they've tried hard. And most people come from the right base. Everyone's well-intentioned. People don't intentionally make mistakes. So if you're providing a safe environment, and as chief executive, if I'm in a position where I'm saying, that's okay, I've got your back.
I'm going to jump back briefly to you spoke about flexibility in the way that you deliver buildings, or you mentioned car parks. A lot of the projects health infrastructures, not a lot. Some of the projects health infrastructures delivered over the last few years have been more on a concession-based model, PPPs with a sort of long-term fixed operating component to them, including and excluding clinical services. There is a perception that those things are perhaps less flexible. Is that a fair perception?
Well, if you take the most recent example of Northern Beaches Hospital, I don't think it's fair. I think the way it's working, by all accounts, is very efficient and advantageous to everybody. I think the use of PPPs is often driven by the government of the day. And I think what we are focusing on now is not PPP in the truest sense, but more around commercial partnerships. What are the other opportunities that you can put into a space? Who can you collaborate with? What does that mean, for a precinct, whether it's collaborating with a university, which then attracts other investment, to give you a whole, because you've got research partners that then gives you a pipeline, which may then give you a leg up into manufacturing, whether it's vaccine manufacturing or different, gene therapies. And there are all sorts of different opportunities in that space.
Do you think we'll see cycles over time where you see traditional PPPs re-emerge, if I can?
Never say never, Adrian.
Yeah, okay. But the cycle has been sort of, there was a throng of private capital-driven projects towards more traditional procurement now.
I think so. And look, if you look at capital at the moment, money's cheap. And I know that when I was at the Sydney Morning Herald Infrastructure Summit, which the Premier spoke on, it's exactly what she said. Money's cheap at the moment. So, it depends what stacks at any particular time as to whether it's an advantageous decision, whether it's feasible or not.
Yeah, I mean, I sort of had a similar question in mind. What is the future of PPPs? And your observation is quite right. Like, there tend to be trends or waves, but in the current environment, I guess, what are the trends around how to manage some of the growing risks and capacity issues in the market that, the infrastructure market is running quite hard.
From a delivery.
Yeah, from a delivery and procurement point of view. So do you find that you're evolving your model for engaging contractors and for delivering those
We are. I think
projects?
HI has always been, in relation to risk, it's letting the partner who is best placed to manage that risk have it. So, on actual physical risks and contamination, for instance, we collaborate with industry. If we know it's there, we'll get a contractor to price that risk. If we don't know it's there, it's best for us to hold that risk because a contractor will just price it in as to what the likelihood is that it happens. If you look at different delivery models, I think we always try and de-risk our delivery. So that might mean doing early and enabling works on a site, having different packages, having a number of smaller packages and then one major package for your main works. It's about how you can best deliver. It involves who's best placed to keep design risk. At what stage should that design be novated from what we hold with consultants to what a contractor might hold? And there's often a debate among consultants about whether they'd like to be novated to a builder or to a contractor or not. And I think it's horses for courses.
On the PPP thing, you mentioned it's the government. That it's interesting that Victoria's procuring 2 major hospitals right now, both through PPPs. Footscray and the other one, the name of which escapes me, Frankston. So Footscray and Frankston Hospital through PPPs, but we're not doing any major PPPs at the delivery point here. But they're both in the same market. So is that, do you think, just reflects of the particular point on maturity curve for government, or is it something else?
I think it probably is largely around that, the maturity of government, different decision makings, how much, what the fiscal responsibility is of government at the time. There's been, through stimulus, there's been a lot of money injected into the New South Wales economy, and some of that is through different hospital projects. And we have a number of projects which have been accelerated through stimulus funding, a number of projects which have been brought forward in that space. So we, as a couple of examples in that, we would partner earlier through an ECI contract delivery model to get a contractor involved early. I think part of that whole stimulus of the economy at the moment is the market's fairly volatile as far as pricing goes. Our own experience at the moment is some projects have come in much better than we were anticipating. We've had some really good savings, but there are a couple where it's like, wow, we didn't expect the market to tell us that. And
that's
so
interesting. It's not
less predictable.
It's volatile.
That's what we're finding at the moment.
Yeah, okay.
But what it does mean in that space is that we're locking contractors in. A big part of it is communicating with the market what our pipeline is, so staying very involved in industry briefings around this is what we have coming up to both consultants and contractors. We're talking with them about what their preference projects would be so that we're getting our tender lists right. We very involved in making sure that we comply with the Premier's 10-point plan. So on our major projects, we only have 3 tenderers. And we're getting much better responses from the market in that space because they know they've got a better chance of winning.
You do always compete at the point of a project. It's not a panel type approach. It's more of
We often run a statement of participation, or we've just gone out to the market for both architects, project managers and contractors to say, here's our pipeline over the next 12 months. Tell us which projects are your target projects.
Yeah.
So that we know what they're interested in, they know what their opportunities are, and we're actually doing a better job at getting the right tender panels together to get better outcomes.
Are there any particular projects or suites of projects you're working on at the moment that are kind of case studies for the best way to do stuff?
I think Concord Hospital is a really interesting example. We've got a project there which is quite close to completion. We were pretty brave in December 2018 in asking the market to price a 5-day working week. And we've done that, where there's some research that we're doing jointly with Roberts & Co., who are the contractors in that space, which University of New South Wales are doing, which just shows the massive improvement in productivity and well-being, feedback from families of workers about how much better it is for them. But interestingly, it hasn't affected program quality or productivity in that space. So, I mean, that's an example of how do we do things differently to do it. And, I'd absolutely do it again.
It might just be worth explaining what the the problem you're solving there? Because you say 5-day working week, there would be some people listening to this that would say, hold on.
So the construction industry traditionally is a 6-day week, or at least a 5.5-day week. And what we were interested in is if construction sites are only open Monday to Friday, excuse me, and if you get a commitment from your contractor and they from their subcontractors that they are not working 5 days on your project and then a 6th day on another project, what is the effect of that on the productivity and what is the effect of that on the well-being of the workers and their families? And what we're finding is it's a great response and it's really worked. It's worked well.
We spoke about gender diversity earlier. I imagine that a 5-day working week is a more family-friendly
absolutely
approach for mothers and fathers alike. Are you seeing, is that extending into benefits for the kind of workforce composition or culture and that kind of?
We're finding that the culture of it promote. We've had feedback that a worker didn't get to a single sports game of their child before this, and they've managed to go to every game or a number of games this season. So it's things which seem simple to us, but actually promote healthy families. For if it means you can go and see your primary school age kids play sport and be involved in that, and there's. It's about different amenities which promote, again, gender diversity on sites, but it's providing, there's age diversity, there's retraining opportunities of, I can think of an example on a site where I met a woman who was an electrician. She would have been a woman in her 50s, late 50s. She'd come back from what she considered to be a menial job, trained, been nurtured in that, and was now a qualified electrician and loving her prospects.
Oh, great.
Can we talk about? I'd be keen to hear what health infrastructure is doing to push towards net zero. So, what does it mean across the program
from a sustainability perspective?
For sustainability, net zero emissions.
We work with a number of local health districts who now have a mandate towards net zero. Sustainability for us, traditionally we haven't gone for a Green Star rating. It's about what's good building design. It's about orientation. It's about having deep window reveals so that you don't have western sun belting in. But we have sustainability as one of the pillars of our corporate strategy around how do we get more out of that. It's around different energy solutions. It's around workforce sustainability as well. It's around better building materials. So it's about everyone doing what they can in every part of the business.
You mentioned your passion for the bush and the regions earlier on the climate change theme. There is impacts from climate change probably largely felt in those regional areas around the health campuses you're delivering. Is there anything you're changing the way you're doing your business from a climate change perspective in those regional areas?
I think it's always around good design principles. And we talked earlier about having hospitals being a nicer place to be. It's things like openable windows in areas. It's about different indoor and outdoor spaces. It's around, we have maternity areas or mental health areas or any different areas that we can, which have courtyard spaces that people can both spend time in but also have their families visit in. So it's around natural cooling around landscape spaces, and so I think it's not particularly different in rural areas other than the scale of the buildings which we're building. They're often smaller, so they're often single story, which means there are more indoor-outdoor opportunities.
You would be quite rare, I imagine, in a leader in the public sector who is not permanently based in Sydney. Does that change? You have a rural perspective. Does it change the way you think about this stuff?
I think it gives me a broader perspective around what the important things are to a number of different communities. So I commute from the North Coast. I work from home some of the time. I travel around our project offices so that I'm in, all over the state. I think I'm lucky. I've got the best of both worlds.
And how many pairs of RM Williams do you own?
We were just counting that before. It's either 4 or 5 at the moment.
So I've got a long way to catch up.
Do you wear them all at any one period of time?
I'm not a centipede, so I only wear 2 at a time.
But as in, would you wear one pair on a Saturday, one on a Sunday? Or do you just, it seems like an awful lot of pairs of boots. This is not my only observation.
Depends what goes with what.
How many pairs of RM Williams do you travel with when you go around the state?
2 normally.
2? Oh, that's a bit different colours, right? Not
blue suede or black leather.
Yeah, okay. Well, I'm going to have to buy some blue suede ones now to catch up with you.
I'm interested in about how best to service remotely, and sometimes you want these really great centralised, centres of excellence. Sometimes you want really close to communities, local responsive services. How do you get that balance when you're looking at regional hospitals, regional infrastructure? And does that balance change over time with technology?
I think it will change over time with technology, because we talked earlier about increased virtual care. But it's about having access of services for different populations. So we have small multi-purpose facilities, which we talked about, which has a combination of acute care and aged care beds. It's around having different community health outreach services, and then you might have a regional referral hospital, a hospital the sort of scale of Armidale, which then might refer to a base hospital in Tamworth. And then if something's significant, that patient might be referred to John Hunter Hospital in Newcastle or to a tertiary hospital in Sydney.
Is that more networked than we might have been 20 years ago?
I think with the advance in technology, it's different services are provided in different spaces. I think it's, and that devolution of healthcare to local health districts, but they all collaborate with each other, and it is about where the service is best available and then what services can be provided to people closer to home as they're recovering.
I don't know if this is a controversial question, but is there a perception that telehealth is a lower standard of care?
It's probably a question for the community about whether it's a lower standard of care. I think there are certain things you can do virtually, and there are certain things which you can't.
Yeah.
And it's around, and it's appropriate for some types of consultations or care, but not for others. It's a bit like, I've noticed a few times lately, you meet someone face-to-face now that you haven't seen after 12 months of Zoom, and you might say, I'd forgotten you were really tall.
Yeah.
But, you only get a certain dimension if you're looking at a screen.
Yeah.
Whereas it's different face-to-face. So I think it really just depends on what it is, the service that you're trying to achieve. And I don't think anyone is ever suggesting telehealth is the answer for everything. It's that it is more efficient and provides you a different service in a number of varying, scenarios.
So I perhaps incorrectly think of telehealth as something when you're already interacting with the formal health system. But there's lots of areas of public policy where we know an early intervention outside of a traditional setting can have dramatic impacts through prevention or whatever it might be. You mentioned $20 billion of capital spend over about 4 years.
That's the size of our planning pipeline. Our spend over the 4 years is 10.7.
Okay, so a couple of billion a year. How much of that, is it the right attention to be placing on building stuff as opposed to taking a small amount of that money and putting it into more preventative type interventions?
Well, I think it's about collaborating with the health system as a whole about how should that service be delivered. We do work with eHealth, we do work with HealthShare around the procurement of different models. We're looking at different statewide services in that digital space. And it's around, if you take telehealth, you said, is it a lesser thing? There've just been new cameras put in, I think, every regional emergency department. So if there's a trauma patient that's come in, whether it's from a farm accident or a car accident or whatever the case may be, that can be beamed directly to, for instance, a specialist surgeon at RPA to give you advice right there while they're right there. It turns on automatically. It's on the spot, having that doctor with you in the room in many respects, where you might have, the hospital model in that small town might be of a GP VMO, so a local doctor who comes in under those circumstances, but you're accessing absolute specialist care, which gives the patient a much better chance of a great outcome.
One of the things I'm intrigued by our conversation is that it stands in stark contrast to lots that we have where all of your responses around infrastructure relate to the service, not the buildings. And when we have these podcasts and broader conversations, everybody's talking about like how great the bridge is or how great the tunnel is. But every time you answer a question, you talk about the service. I don't know that I've got a question in that, but like, do you just think about it differently, or do you not like buildings, or that's why?
I love building.
Yeah.
It's about building the right building to get the right outcome. So I've spent more time kicking around in steel cap boots with a hard hat on than I have in a suit at Barangaroo.
Yeah.
So it's around making sure that we're building the right things.
So I think I think what's interesting about the sort of service health, the service/infrastructure divide is, like, if you look at transport, so much of the cost is around the actual build and the asset itself, whereas in health it's actually smaller relative to the service that's provided. So I think the focus ends up being on the actual service interaction, the patient. It is a slightly different discussion.
And I think our focus needs to be on that recurrent component to make sure we're spending the capital in a really sensible way to allow it to be affordable to run.
Yeah. I mean, it goes to a question I had, which was around, like, when you design a health facility and you think about agility and, the ability to remodel it in the future, or, what new systems or new technology it might need inside of its walls, does it sometimes feel like you're the tail wagging the dog, because you might actually be moving ahead of where practitioners are at that point in time?
I think, to go to Adrian's telehealth example, that was absolutely the case. The technology was there before COVID, but there was a reluctance by a number of clinicians that said the patient's got to come in and sit in front of me in a consult room. Now, that's changed by necessity, and I think we'll see more and more of that.
So is your future, rather than being a built form infrastructure provider, more of a technology provider?
I think we'll have a stronger advisory role. We've got a stronger role in that whole of life asset planning piece, assisting the districts and the networks around how they need to be doing that asset management, how that needs to be informing what the capital should be spent on, so that it's not just, we need a new hospital here, what should it look like? It's what is the actual life expectancy of facility XYZ, and therefore when do we need to plan to build a new hospital in that location?
I have my closing question.
Go for it.
Oh God, is that a tricky one?
As a landscape architect who, as we've come to understand, is obsessed with service delivery but interested in the built form, what is your favourite sort of infrastructure and why?
I was fortunate enough to work for NASA for a couple of years, not as a landscape architect, but on their leadership program. And I worked out that it really doesn't matter what infrastructure you're working on, we're all people. So I was working on a leadership program with a bunch of really wacky rocket scientists.
Cool.
But at the end of the day, and it was a fantastic experience, but at the end of the day, they were just people.
Right, cancel the whole podcast. I want to talk about NASA.
I know, I want to talk about NASA as well.
You worked at NASA?
What was your role when you were there?
I was one of the presenters on their leadership program.
So you taught rocket scientists leadership?
That was the ambition. Yeah, absolutely. It was about.
Yeah.
It was great. It was a fantastic program to be involved with.
How did you get that position? What happened?
It was actually an opportunity which arose when I was doing my master's in project management at UTS, and one of the guest lecturers ran the training and development program at NASA. So it was just an opportunity which presented itself that I thought was too good to refuse.
So are you saying your favourite sort of infrastructure is rocket launching infrastructure? Is that?
That was what I was going to say, but I think I'd have to say my favourite type of infrastructure is providing different infrastructure for communities to make better communities. Like, I'm passionate about working in health because it's providing great outcomes. It's providing better things for more people. It's about making people's lives better. I
mean, it's a great answer, but I wish it was rocket launchers. We've had lots of tunnels, lots of bridges, but rocket launchers would have nailed that question.
Yeah. Can I ask one question? Just about the Olympics work that you did. I read in an article you really attributed to the 2000 Olympics your discipline and your meticulousness at work. So what sort of led to that? Like, what was that like going through that period of time?
Well, the opening ceremony was always going to be on the 15th of September 2000, so we couldn't move that. I was very fortunate to work with Bob Leese at that time, and he was a great believer in getting things done, that you needed to be disciplined with processes but have a go. So, the 80% rule that we talked about earlier, that was an absolute Bob Leese mantra. You're better off doing something than doing nothing. So start your planning, get the right people around you and the right teams. You set off on that journey, and then you can fix up some bits and pieces along the way. But you really need to you get going, and it's around that. Well, it's that balance of discipline and agility.
We just had a thing called Queensland Infrastructure Week, and Brisbane's staring down the barrel of potentially winning the 2032 Olympics and Paralympics, and there's so much focus on this idea that there's a date and it's going to happen, and that kind of everybody coalesces around it. So it's interesting. Your go-to for that is that it was happening that day.
That's
so we
right.
had to deliver it all.
Yeah.
There's maybe a parallel with things like a pandemic where there's a common enemy or a common outcome everybody wants to achieve that just lets you kind of cut through the...
And I think that's one of the things I was proud of during that pandemic response was that health infrastructure could help in that space, because we can, it's about how you get it done. It's not about necessarily following the process, a very linear process. It's about harnessing some bright young minds and about how do we do this the best way? What else can we think of? And then overlaying that with some experience and saying, what's the best way to do this?
Well, I think that's a great note to finish on. Thank you, Rebecca Wark, for joining us on Inside Infrastructure.
Thanks, Adrian and Janice, for having me. It's been a great chat.
Thanks, I've really enjoyed it.
Thank you for listening to this episode of the Inside Infrastructure podcast. We hope you enjoyed our conversation with Rebecca Wark. Please make sure you subscribe on your favourite podcast platform. Leave us a rating and review or comment on LinkedIn. And as always, please feel free to send your suggestions to Adrian or myself. Your feedback is invaluable. Join us again next month for another conversation with one of Australia's infrastructure leaders.